the next, so with that background, the next thing that we need to do is to know something about toric marking, because a lot of error happens either in measurement or in marking. So when you look at something like this, it's not really easy to figure out where the problem lies. Okay, but if you concentrate on the Purkinje light reflexes, you are holding a light right in front of the individual, you see the Purkinje light reflexes. Once you concentrate on that, you can figure out where the head is slightly tilted or not. All methods of marking give a perfect mark parallel to the ground. But if the head is not perpendicular to the ground, you start with maybe 5, 10, 15 degrees of error. So no amount, it doesn't matter whether you're doing a 200 rupee hand-free marking or you're using one of those electronic markers which is $2,500. If the head is not perpendicular to the ground, you are starting with a big error anyway. So here, it is necessary, I feel, in all marking to look at the Purkinje light reflexes of both eyes, draw a line through them, and then you are able to see which eyes are parallel and which eyes are not parallel to the ground. And using this line reference, then concentrate on one eye, figure out which is the horizontal, and then proceed further marking that one. So during marking, reference mark is on the slit lamp, patient seated, no cyclotorsion. At that point, you mark 0, 180. Intraoperatively, the next step is to mark the preferred axis of the lens implantation. Multiple equipment are available, and all of them have this vulnerability that the head may not be aligned properly. IOL then alignment, 3 steps: gross alignment of lens, remove the viscoelastic from behind, and final alignment. So this is freehand marking. You just use trypan blue or methylene blue, and you get various instruments, 0, 180. Make sure that the patient is well anesthetized. Talk to the patient, reduce anxiety before you do it. This is our current preferred technique of marking. Seat the patient properly on a slit lamp. Make sure the 2 eyes are parallel to the ground. Use a thin slit beam and then mark 0, 180. And then at that time itself, you can also mark the axis of the IOL implantation. My colleague Dr. Himanshu, who was there in that video, prefers to use a needle in order to avoid smudges with the methylene blue. So this is intraoperatively. 0, 180, the reference is marked. The 30 degree for the incision is marked, and the 130 degree for the IOL position is marked. It is essential to do this with the cornea somewhat dry, because if there is any jelly fluid or viscoelastic on the cornea, you will get a big smudge and you will not be able to proceed with surgery. So these steps are pretty routine. I just want to show this case, which was intumescent cataract, that it doesn't matter what you start with, flawless surgery is necessary, because if you create a rent or have complications, as will be shown by Dr. Adrian next, it becomes very difficult to achieve what you have promised for the patient. So this is grossly speeded up in the interest of time. I don't normally operate that fast. Okay, so you complete the thing. Next is IA and cleaning the cortex. It is necessary to do a thorough polishing. When I started doing toric IOLs, I used to leave a little bit of the material there, or I never used to polish the anterior capsule so much because I thought it helped in adhesiveness. But today I polish it nicely, because later on, if you have too much of a anterior capsule opacity, you cannot make out where the toric axis is. So today I polish it nicely. After putting the lens inside, I am using irrigation to try and get the viscoelastic out from under the lens. I am bringing the axis maybe about 5-10 degrees off. So this is the gross alignment. At this stage, it is a good idea to ensure that viscoelastic under the bag, inside, against the endothelium, all that is completely removed, and you don't want to complete a final alignment and then have the chamber collapse. So at this point, I ensure that the main ports are hydrated and the chamber is formed. Amount of collapse that can happen subsequently is less. You can see good 10 degrees maybe difference between where it is and where it should be. Then irrigation on, you don't want viscoelastic in the eye at this stage. You do your fine alignment using a second instrument. Important at this stage is to make sure that the eye is properly aligned and you are not creating some parallax in where, because that will make the lens alignment off. Pupil, one of the challenges in a lot of toric IOLs is that the pupil tends to become smaller by the end of the case, and so it is nice if you have a good dilated pupil, and challenges with small pupils Dr. Adrian will be showing. So you can see as I am injecting the hydrating the side ports, there is some amount of tilt. You can see that it looks parallax appears. With the eye in the native position, it is beautifully aligned in this situation. So this is what gives you a good result. Okay. A lot of patients will come and ask you for multifocal lenses. Very few people come and ask you for toric. You need to sell the idea of a toric lens to patient. And it is beautiful technology, very forgiving technology. So these are the conventional methods. A lot of companies have invested a lot of money in other systems. So the Varion is one of them. Callisto is from Zeiss, Varion from Malcon. These are equipment which help to grab the image. They recognize the limbal vessels, iris pattern, etc. You register that image, and if the image meets certain parameters, you accept that image, and then the information, keratometry, etc. goes into what is called as a planning unit. In the planning unit, you can choose the lens formula you want to use. You can take a decision on whether you want to correct the astigmatism. If you are correcting astigmatism, whether by incisional methods, or you can choose to correct it by IOL, partly by incision, partly by IOL, fully by IOL, etc. And then after completing the planning, you transfer it to the intraoperative unit. Suppose you have access to a femto machine. That information comes into the femto machine, and the iris pattern and limbal vessels are recognized, registered, and the docking happens appropriately. It will give you this information, registration successful. Then obviously the incisions will be placed on the axis that you had planned. A case can happen exactly where you planned. Otherwise, you take the incision information directly to your operative microscope. There, the incision positioning, the rexis, the IOL centration, and most importantly, the toric alignment of the lenses can be done in a markerless fashion. And it is supposed to be more accurate, but you have to decide whether the cost is justified. What closes the loop actually is this newer technology from Alcon, which is Aura, and another company has also got it, which is called Holos, which gives you an information that what you have planned and what you have executed, are they close together. It doesn't help you too much if 1 week later or 2 weeks later you know that the lens is off position, because by the time the patient gets very agitated. If you know it on table, you can fix the problem on the same sitting. So information, light reflected back from the retina, goes through a series of sensors, and you get real-time information whether the sphere is appropriate, whether the cylinder is appropriate, whether the cylinder needs to be rotated, and it also accounts a little bit for the alteration caused by the incisions that you have created. It is vulnerable to the effect of your speculum, etc. So this is an evolving technology. So basically, you can capture the image, make the surgical planning. You can have certain amount of intraoperative guidance on the two equipment, and verify that you have executed what you had planned, and hopefully these technologies in future will help you to optimize your clinical outcomes. My area of interest in astigmatism came up as a result of my PhD work, and Mukesh touched a little bit upon topography. So the question is, does topography take care of everything? Biomechanics possibly also has a role, and the interest in this happened with a 21-year-old female who had a very early PSC. Pre-op pentacam showed astigmatism fairly regular, and the higher order aberrations were not too bad. But 6 weeks post-operatively, when we saw the patient had about 0.5 cylinder centered diffractive toric multifocal with axis very close to where it was planned, and the patient was extremely unhappy. We checked the axis as per the assessment on the eye trace. It was on schedule. And then what we found that had happened was that this lady had astigmatism 2.2 pre-op, and by 6 weeks post-op the astigmatism was only 1.2. So I had made the incision on the steep axis. With a 2.2 keratome, I expect to have maybe 0.25, 0.2 or maximum 0.5. This one had actually ended up with a diopter of flattening. So what we realize is the cornea is a viscoelastic tissue, deforms differently when stress is being loaded, and when it is being unloading, the difference is there, and this difference is what they call as corneal hysteresis. Our friends who do a lot of keratoconus work are very well versed with this problem. Okay, and there are equipment today which measure this deformation, that's called as the Corvis, and the peak to the maximum displacement is captured on high-speed Scheimpflug imaging. And we know that cataract surgery, when you make an incision, the biomechanics is changed. We also realize now that biomechanics alters the outcome of your cataract surgery. So in this individual, the biomechanics was poor. The deformation amplitude was more than 1.19, and what had happened in her was that the remodeling of the cornea, usually by 3-4 weeks later you expect that the cornea is healthy. In this individual, it went on for 8 to 9 months. So that 1 diopter of flattening reduced to about half diopter of flattening by about 6 months, and 0.75 diopters, 0.25 diopters of flattening by about 8 to 9 months later. And during this entire period of time, the individual is having additional unnecessary toricity inside the eye. This was a learning curve for us, and that is where my PhD work started.